Hello and welcome. On behalf of CME Outfitters, I would like to thank you for joining us for today's educational activity titled Evidence-Based Strategies to Facilitate Access to Therapies for Patients with Spinal Muscular Atrophy. This activity is supported by an educational grant from Biogen. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Today's CME CE activity is also eligible for ABIM MOC points. Once you complete today's program, be sure to provide your ABIM ID and birth date in the evaluation. CME Outfitters will submit your MOC points. If you would like to claim this activity as a CME for MIPS improvement activity, follow the steps described on this slide. I'm Dr. Crystal Proud, Director of the Neuromuscular Clinic and Spinal Muscular Atrophy Center at the Children's Hospital of the King's Daughters, and Medical Director of the CHKD Novel Therapeutics and Gene Therapy Center in Norfolk, Virginia. I'm joined today by my colleague, Dr. Erin Neal, Clinical Assistant Professor of Pediatrics, Director of the Pediatric Neuromuscular Program, and Co-Director of the Muscular Dystrophy Association Clinic in the University of Michigan Medical School, as well as the Medical Director for the State of Michigan's SMA Newborn Screening Program in Ann Arbor. Welcome, Erin.
Thank you.
Let me review our first learning objective, which is to determine the tests and clinical assessments that can aid in diagnosing SMA, as well as monitoring disease activity and treatment response. Spinal muscular atrophy manifests as a phenotypic spectrum. This is a progressive, recessively inherited neuromuscular disease, and is characterized by weakness and muscular atrophy due to the loss of spinal cord motor neurons. It's one of the leading genetic causes of death in children, second to cystic fibrosis, and has a high carrier rate of about 1 in 50, with an incidence of about 1 in 10,000 live births. It is due to a deletion or mutation in the SMN1 gene, and so we'll take a moment to talk a little bit more about the genetics of this disease. SMA results from SMN protein deficiency, and this survival motor neuron protein is produced by 2 different genes in the body typically, the SMN1 gene and the SMN2 gene. The SMN1 gene is very efficient at producing this protein, but the SMN2 gene is inefficient at producing this protein. And this is because during transcription and translation, there is a process called alternative splicing that occurs, whereby sometimes exon 7 is included in the mRNA, and sometimes exon 7 is excluded. When it is excluded, it is non-functional protein that is broken down and does not support the health of the motor neuron. And this happens about 90% of the time when the protein is being produced by the SMN2 gene. So only 10% of the protein that is produced by the SMN2 gene is actual functional protein that can support the health of the motor neuron. Patients with spinal muscular atrophy rely solely on this backup SMN2 gene because they have a missing or mutated SMN1 gene. And that SMN2 gene cannot keep up with the necessary protein production. And as a result of this insufficiency, we see progressive motor neuron degeneration and then progressive muscular weakness and atrophy. Erin, can you talk to us a little bit about the various phenotypes and how prevalent is each type, and what might lead to a delay in the diagnosis?
Sure. So there are 3 or 4 types of SMA. They are traditionally, historically diagnosed based on the maximum motor skill that a child or a patient would attain. Type 1 SMA is typically thought of as not ever able to attain sitting, and their onset of disease activity is before 6 months of age, so very early. And prior to the advent of treatment, they had very limited lifespan, about 8 to 13 months of median kind of survival. And only 8% typically were surviving or alive at 20 months of age. Because of the significant motor weakness, they have early onset dysphagia, and accompanied by respiratory failure. And although this is not always the case, typically they would have 2 copies of SMN2. This is the most common type of SMA, and it's about 60% of patients with SMA. The second type is type 2. They are traditionally thought of as able to attain sitting, but typically do not attain walking. And they, in general, would present with symptoms between about 6 to 18 months of life. There's obviously a delay in diagnosis if we're waiting for someone to develop symptoms of SMA before they are diagnosed with it. And therefore, their life expectancy, while longer than someone with type 1, is going to be shortened from a typical child. They, in addition to having respiratory disease, also oftentimes develop skeletal challenges, including scoliosis or contractures or kyphosis. And patients with type 2 can develop breathing impairments and also sometimes difficulty with swallowing as well. And this is the second most common type at about 27%. And then type 3 is the least severe. They typically present with symptoms after 18 months of age. And there are kind of 2 different categories of type 3 based on how early or late they present. And the earlier presentation has a higher risk of losing the ability to walk earlier. Their life expectancy typically is actually normal, and they have more mild weakness, specifically in the lower extremities and the pelvic girdle muscles. And typically they have between 3 and 4 copies of SMN2, but this is not always exact. And this is about 12% of the population. And all types of SMA, if they are diagnosed once a child has clinical symptoms, by definition means that there is a delay in diagnosis compared to if a diagnosis is made based on newborn screening, which would identify patients before they ever have any symptoms. When we look at SMA and we're measuring how a patient is doing, we use some standardized motor outcome measures to assess how a patient is progressing once they either prior to treatment, how they were losing skills, but now in the world of having treatment for SMA, we're looking at how patients are actually improving in their motor skills. So younger patients typically are measured with something called the CHOP Intend or the Heine-2. And there are different categories in each of these motor outcomes that are tracked over time. And then in older patients, oftentimes something called the Hammersmith or the MFM 32 are what are used, or the upper limb module. And then in patients who are actually able to be ambulatory, you can do a test called the 6-minute walk test and be able to measure over subsequent testing sessions how far they are able to walk and monitor that with time.
I think that many clinics that have the capacity to be able to perform these clinical examinations attempt to do the most relevant of these in clinic. I know that our neuromuscular physical therapist is able to help facilitate these assessments for us about every 6 months. And some of those might be impacted by the child's ability to participate in that examination or the age at which we think it might be most appropriate to have that testing performed. And we generally try to have a bit of an overlap. So we're going to, start in our younger ones with the Heine section 2 and the CHOP Intend. And eventually we'll say, are they old enough that they can follow instructions to start doing some of the tasks we're asking them to do on the Hammersmith, but we won't make that our only examination. We'll still do the Heine and the chop and tend while we're getting them used to the Hammersmith, and then we might add in the Rollm while we're kind of moving on from the chop and tend and the Heine. So it does tend to be this spectrum of assessments that we transition through these days. We recognize that one of our biggest challenges can be approval by payers, and motor outcomes are really a key measure to be able to provide some data to support our requests for authorization and for reauthorization. And so it's worth talking a little bit about what measures qualify for initiation and continued use of therapy. And I think one of the most important things that we need to highlight when we're considering this is the fact that SMA is a progressive neurodegenerative disease. And when we impact a disease like that, we may be able to demonstrate improvement in outcome. We may be able to improve motor strength, for example. But in a case where we have progressive deterioration in the absence of treatment, stabilization should be considered success. And so for many of us that treat these patients, that's the kind of conversation that we have with them when we're talking about initiating treatment and continuing treatment. We're very hopeful that this will help you improve your strength. But even if it doesn't help you improve your strength, if we can maintain your strength, or even if we can slow the deterioration, that is considered success. So it can be a challenge sometime when we're trying to authorize these medications, and we see very strict criteria, such as you must improve by 2 points or more on your Heine or your chop and tend or your Rollm or your Hammersmith. And we know that that is not necessarily consistent with success in a disease like this. We can still discuss optimization of outcomes and efficacy with stabilization or even a slower decline. And so those are conversations I think that will evolve over time. So let me get our audience involved. I have a polling question for you. Which is true of a positive test result from a newborn screen for SMA? So it appears as though our audience has chosen option D, and option D is the correct answer. Follow-up confirmatory testing is needed. Erin, can you talk to us a little bit about screening?
Sure. So newborn screening in the United States is under a program called the Recommended Uniform Screening Panel. And this is a panel to which a condition can be nominated and added. And SMA was added to this, it's called the RUSP, in 2018. And as of April 1st, 2021, 36 of the 50 states in the United States are actively screening for SMA. And that results in about 71% of infants born in the United States who are being screened for SMA. This is quite remarkable, as it's allowed us to identify these patients much earlier before they actually are symptomatic. In states that do not have newborn screening, children are added to a parent's insurance, and usually they are enrolled within about 30 days after they are born. And the ability to cover a newborn is retroactive back to the date of birth. And typically coverage is submitted under the mother until the newborn is enrolled if there needs to be a treatment or testing of a child.
We're thrilled to see that newborn screening and states participating in newborn screening are expanding. I'm thrilled that my governor just signed ours into action day before yesterday. And so hopefully we will be screening a bulk of the infants born throughout the United States soon. So let's transition now to discuss a case. Case study number 1. 2-day-old baby Carrie presents for evaluation given the parental history of both the mother and father being carriers for SMA. Carrie has a sibling with SMA. On neurological exam, I see no specific areas of weakness or low muscle tone observed, although reflexes are absent. And Carrie was born in a state without newborn screening. For our second polling question, what is the best course of action for this baby? So newborn screening does not provide an SMN2 copy number in most cases, and so additional testing is needed to confirm both the absence of SMN1 and SMN2 copies present. And it may also help to facilitate resolving discrepancies in the SMN copy number. It's important to avoid treatment delays because this is the best opportunity for a normal or a near normal outcome. Immediate treatment has been recommended for infants with less than or equal to 4 copies of the SMN2 gene. And treatment risk with discussion of pros and cons with the family should be congruent with the disease severity. It's critical to avoid treatment delays. And so let's go over the testing algorithm for a suspected patient. So if I see a patient in clinic who is symptomatic, or I have a patient who is suspected of having SMA, even if that is a patient who's identified on newborn screening, I'm going to pursue the following algorithm. I'm going to collect a sample, whether that is blood or saliva. In most cases, it's blood. And then this will be sent off for SMN1 deletion testing. If that sample demonstrates that there are 2 copies of the SMN1 gene, then this is not a patient that has spinal muscular atrophy. If this testing demonstrates that there is 1 copy of the SMN1 gene, we have to ask ourselves whether this is a functional gene copy. And the best way to examine that is by sending this testing for sequencing. If there's no sequencing abnormality, then this is not a patient that has spinal muscular atrophy. If there is a sequencing abnormality in that 1 copy, it means that 1 copy of the SMN1 gene is not functional. And therefore, this child does have a diagnosis of spinal muscular atrophy. The most classic condition, the one that most of our patients are dealing with, is testing that will show that they have 0 copies of the SMN1 gene. With each of these tests that are sent to commercial laboratories, we should be receiving those test results also demonstrating the backup copy number, the SMN2 copy number testing. And when we're discussing the SMN2 copy number with families, we might use this to help facilitate our discussion. But I'll have Erin talk with us a little bit more about why this might not be an exact measure to predict the outcomes for these patients.
Right, Crystal. So while we use SMN2 copy number as helpful, it's not an exact translation. So, you know, there is a nice study done in Spain looking at 625 patients with diagnosed clinically with SMA, and they looked and found that in patients who had clinically had type 2 SMA, about 87% had 3 copies of SMN2. But you know, that's not 100%. There are some patients who don't have 3 copies, but still will present as clinically having type 2. And then type 3 is even less kind of uniform, where there was about half had 4 copies, but you know, the other half had either 3 copies or more than 4 copies. So especially now that we have newborn screening, where we're going to be identifying copy number, but not having any clinical symptoms yet, it's really important to highlight the fact that treatment is not defined by copy number. And, you know, we are, especially if we're treating patients who are clinically affected, it doesn't really matter their copy number. If they have symptoms, they should be treated. You know, I have an example of 2 patients who were diagnosed pretty close together, who one patient has 3 copies of SMN2 and is walking independently. And I have another patient about the same age who has 4 copies of SMN2 and is not walking independently. And, you know, it's just example of the variation that comes with SMN2 copy number, while it oftentimes is helpful, it's not exact. And this leads to kind of the next slide, talking about some articles that were published by a group of experts looking at, in 2018, they made recommendations prior to the approval of some of the drugs that said, in newborn screening, patients who have 2 or 3 copies of SMN2 should be treated immediately, but patients who have 4 or more copies, perhaps we should wait and see what when they develop symptoms, and then initiate treatment. However, in 2020, the same group kind of revised their recommendations and said, it is true that even if you have 4 copies or more of SMN2, you are actively losing motor neurons all the time. And so they've actually revised the recommendations to say, if there are 4 copies of SMN2 on newborn screening, those children should also, or babies should also be treated immediately with one of the treatments. So, I think as time goes on, we are kind of making changes and learning even more about treatments and how patients respond to them. So let's go back to case number 1. So again, we have this 2-day-old baby. Mom and dad are both carriers. She has a sibling already who has SMA, and her exam is relatively normal other than her absent reflexes, and she's not in a state that has newborn screening. So let's go back to see about the best course of action. Wonderful. So it looks as though the audience, even before and after, recognize that the correct answer is B. You want to, or especially since she's in a state without newborn screening, you're going to need to order SMN1 deletion testing to determine what is her copy number of SMN1. And then if she has SMA and does not have any copies of SMN1, you will also get an SMN2 copy number to determine that number as well. And then regardless of that SMN2 copy number, standard of care is just to initiate a treatment and have a discussion with the family about which treatment they would prefer.
Thanks, Erin. Now let's turn to SMA treatments. Our second learning objective is to apply the latest clinical evidence to evaluate the cost effectiveness of approved and emerging therapies for spinal muscular atrophy. For this section, we will focus on SMN modifying therapies. So we'll start with discussing ways to optimize SMN protein production, including SMN2 splicing modifiers like Nusanierson, which is an antisense oligonucleotide, and risdiplam, which is a small molecule, and branaplam. There is also another modality to optimize SMN protein production, which involves gene transfer therapy, such as onasemnogene abeparvovec. SMN-independent therapies include the ability to optimize muscle membrane stabilization through things like myostatin inhibitors, like apitegromab or SRK-015, and consideration for intervention with things like fast skeletal muscle troponin activators. So we've come to the first polling question for this section. So the correct answer, which seems to be noted by our audience, is A. Nusanierson is dosed intrathecally in multiple doses. Erin, if you could walk us through a little bit more about Nusanierson, onasemnogene abeparvovec, and risdiplam, that would be wonderful.
Yes, so we have 3 treatments that are FDA approved for SMA. The first that was approved was Nusanierson in December of 2016, and it was approved for all types of SMA for children and adults with no age restrictions and no SMA type restrictions. So Nusanierson is administered intrathecally, and it's given as 4 loading doses that are given 2 weeks apart for the first 3 doses. And then 4 weeks after the 3rd dose, the 4th dose is given. And then after the 4 loading doses, patients receive their maintenance doses every 4 months. The potential side effects or adverse effects from Nusanierson are related to the fact that it is a antisense oligonucleotide. And so things that are considered are effects on the kidney, including proteinuria. And so before each dose, patients have urine protein checked. And then also it can affect clotting. And so with thrombocytopenia, so platelets are always checked as well as clotting factors before doses. And additionally, because of the mechanism of administration, side effects can include complications related to lumbar punctures, such as pain or headache or infection. But obviously those are limited or tried to avoid by how the drug is administered. Parvovec is a treatment that was approved in May of 2019. It is approved for patients who have not yet turned 2 years old. And it is different from Nusanierson, and that is it is given as a one-time dose intravenously, and it takes about 60 minutes for the infusion. Its main potential side effects are related to the liver mostly, and can be associated with transaminitis. For this reason, patients are started on a daily dose of prednisone or prednisolone the day prior to, and then subsequently each day for a few months after they've received the medication. Also, troponin can be elevated at times after doses of the gene therapy. Risdiplam is our most recently FDA-approved medication in August of 2020. And it is approved for patients who are 2 months or older. It is given as a once daily, every day oral medication. It can also be given through a G-tube. And it can have some interactions with other drugs. So that's an important thing to take a look at. And then the other potential things to think about are that there's some evidence that it can affect kind of long-term, both male fertility as well as potential effects on pregnancy. And so recommendations are that a female not become pregnant while on risdiplam or for 30 days following. And then its kind of most significant adverse effects include diarrhea, vomiting, and rash. So all three of these medications had numerous clinical trials before receiving FDA approval. And so I'm going to go through some of the trials that were done. So each of these are categorized into the drug and then which clinical type of SMA was tested. So with Nusanierson, the initial trials were in infant onset SMA type 1. And they did a few studies with those patients. Then they also tested patients who were pre-symptomatic. And this was several years ago. So this was either with some states who were doing pilot studies of newborn screening, or they were patients who were identified because their siblings were already known to have SMA. Nusanierson was also tested in later onset types 2 and 3 SMA. And then most of the patients who have been treated have continued to be followed by the company. Testing or clinical trials for Parvovec focused mainly on infant onset SMA type 1. They tested babies with both 2 copies and 3 copies of SMN2. And then they also had a study looking at pre-symptomatic babies who would be predicted to be in the future type 1 SMA. And then again, rollover studies for all of the previously treated patients. Risdiplam has been tested on probably the broadest age range of patients, just as the others with infant onset SMA type 1, pre-symptomatic babies, and then later onset of SMA, but ages all the way up to 25. And then again, previously treated patients in any of the trials. So as we discussed before, we use motor, kind of standardized motor outcomes to help us measure how a baby or how a child is doing. So let's go to our next polling question. Okay, thank you. We're going to revisit that question later and move on to some of the clinical trial results for the different medications. So the first slide is looking at Nusanierson, specifically in the Heine 2 scores. So this is a slide looking at all of the different trials that were done and the kind of outcomes over time. So as you can see in the 2 studies at the top, which were the studies of patients who were pre-symptomatic, but were predicted to be a type 1 in the future. They had the highest, most robust response in their motor outcomes scores after treatment with Nusanierson. And then additional studies, there's been an observational cohort study in adults with SMA. And this was observational, looking at patients with types 2 or 3 SMA who had reached adulthood with kind of various motor abilities or dysfunction and had slow but ongoing disease progression. And this showed that over time, over the course of 6 months would be at about, if you've received all of your loading doses, but not yet received a maintenance dose, all the way up to 14 months. So over time, these patients had improvements in all of the milestones that were measured. So the Hammersmith, had more than, there was a good number that were getting at least 3 points improved throughout the entire the time they were followed. And then their change in their 6-meter walk test improved by double-digit meters. And it's important to remember that these patients are adults. They've had SMA ongoing, and again, as Crystal related before, we expect that SMA is going to get worse over time, and these patients are going to be losing function. So the fact that over a year after with treatment, they are improving. So it's treating adults with SMA and can yield improvements, and therefore we don't just treat patients who are infants with these treatments. So Nusanierson is the treatment that's been available or FDA approved the longest, and so there is quite a bit known about some of the challenges or side effects, and then some real world experience with this medication. So potential side effects, as I mentioned before, include pain and complications related to lumbar puncture. Some patients sometimes get headache. But we also know that because of the method of injection or of administration, sometimes this can be challenging in patients who have scoliosis or kyphosis. So sometimes fluoroscopy is used to administer the medication. Sometimes a CT guided injection is used. In patients who have had spinal surgery, sometimes a laminectomy needs to be utilized to make sure that access is attained. And then sometimes sedation is needed, but not always. Many times these children can do quite well without a lot of sedation. So as far as real world evidence, there are registries that are kind of ongoing to monitor patients that are receiving this drug commercially. And I think some of the concerns that clinicians have is that the dose of Nusanierson is 5 milliliters or 12 milligrams, regardless of patient size or age. And there is some discussion about if that is going to result in some challenges. Additionally, the medication, when given in the typical location for lumbar puncture, there's question about how how thoroughly does the medication, travel up and down the spinal cord. And that's a hard question to answer. Additionally, patients that have received Nusanierson, some of them have continued to have progression of their scoliosis, and sometimes that has created challenges as far as continuing to administer the medication. And then I think COVID has also definitely introduced new things that hadn't really been thought of before, including that in order to receive Nusanierson with intrathecal injection, it means coming to some sort of medical facility every 4 months. And that has resulted in some patients and some families being a little more hesitant about that, with COVID now being introduced into the equation. Crystal, I'm interested if there are any kind of real world experience that you've had.
Yeah, so my practice sees both adult and pediatric patients. And so my youngest patient that I've treated with Nusanierson was just a couple weeks old, and my oldest patient is 68. And so we experience different obstacles and different successes with each of our patients. I have been impressed by my patients' ability to be able to tolerate repeated lumbar punctures, and they do really well with distraction, playing games, listening to music, talking with us about their day. And actually, many of them dislike the venous puncture to be able to get their screening laboratories. Much more, they have much more difficulty with those labs being drawn than they do with me doing their lumbar puncture in a matter of 5 minutes. So they've tolerated it really well, and the need for us to be able to pursue sedation has really declined over time. Actually, I don't think I have any patients who require full sedation right now, perhaps just a little mild anxiolysis with some oral Versed. Let's shift gears now and talk a little bit about the next drug approved, which was gene replacement therapy on onasemnogene abeparvovec. And so in the very first study, this was performed out of Nationwide Children's and is referred to as the START study. It was a phase 1/2 study evaluating intravenous one-time administration of gene transfer therapy utilizing an adeno-associated viral vector to deliver the SMN1 gene in infantile patients. And so these were symptomatic patients that were treated and then monitored over time. We see that there was an improvement in survival and freedom from permanent ventilation. And I think the most impressive figure is the one on the right, where we see that all but one of the patients crossed a CHOP INTEND score of 40. And the reason why this has a dashed line is because historically patients with a phenotype of type 1 SMA never achieve a CHOP INTEND score of 40. And so it was remarkable to see that these patients improved. And if you look at the rate of rise, they improved quite quickly on their CHOP INTEND score and then maintained those scores above 40, several of which were actually considered within the realm of normal eventually. So pretty exciting for these infantile SMA patients. This trial was expanded and ultimately in a trial called the STRIVE study in the United States. This was a trial examining commercial product, once again in infantile phenotype spinal muscular atrophy patients. So these were once again symptomatic patients, and their outcomes were compared with data from natural history. And one of the natural history cohorts is called the PNCR cohort. And so it was noted that once again, survival was improved compared to the natural history, 90.9%. So 20 out of 22 patients were surviving free of permanent ventilation at age 18 months. And prior to age 13.6 months, one patient passed away, unfortunately, at 7.8 months due to a respiratory failure not considered to be related to treatment. And one patient withdrew consent at age 11.9 months. And this patient also required permanent ventilation at 11 months. So let's talk about potential adverse effects with onasemnogene abeparvovec. There is serious potential liver toxicity that I highlight when I'm talking with my families. And this is something that should be considered and discussed and approached with the family as something that we address. And we address this by requiring prednisolone dosing at 1 per kilo per day. There are some institutions using 2 per kilo per day, starting the day before infusion and then continuing for at least 2 months after dosing of the product, with lab monitoring subsequently helping to guide the eventual weaning and discontinuation of the prednisolone. And then we monitor labs pretty closely after infusion. It's pretty common for me to see thrombocytopenia on the first week's lab work, and then that is usually transient, returning back to normal platelet count by the second week's labs. And then it's not uncommon for me to see a transaminitis somewhere between week 2 and 3. And usually I'm not finding myself having to intervene, but if I am seeing that those continue, then I may adjust my steroid dosing. I've done things like increase to 2 per kilo per day. I've administered IV Sulumedrol, and I've seen those transaminitis numbers return back down, and then we're able to successfully wean and discontinue. There is a Restore registry that is ongoing that is not just for patients treated with Sulgenisma, but is also for patients who were diagnosed with spinal muscular atrophy and have received any treatment or no treatment at all, in order to be followed. And hopefully those outcomes will help us to have a more knowledgeable discussion about the evolving landscape of spinal muscular atrophy patients over time. It's important to consider discussions around vaccinations, especially when giving prednisolone, and we know that those vaccinations may not be as efficacious. And so we have those discussions, and then also pass that along to the primary care pediatricians as well. And then we share information about potential viral vector shedding, and the need to utilize gloves and good hand washing for the first 1 to 2 months after dosing. I'm interested to hear Erin's experience, but right before we jump into that, I wanted to actually take an audience question that I see that has come up. What is the oldest age within the label that you've treated a child with Sulgenisma? And I actually have treated a child who was 23 months. He was 1 week from his second birthday. And it was quite a big decision for the family to make to pursue that treatment. And ultimately, we infused 1 week before his birthday. And actually on his birthday, he started being able to roll around the floor and shortly thereafter sit up on his own. And he is now walking, which is really exciting. So Erin, any other things to add about real world experience?
So I think it's things that I have kind of learned is that it's really important to consider the viral vector shedding, especially if the parent of the mother of the patient would happen to be pregnant. If she is pregnant and the fetus being carried would happen to be affected by SMA, we have to be really, really careful that the mother does not develop the antibodies to the AAV9 vector, or if they are passed on to that fetus, then the fetus would not be eligible for the gene therapy. So that's a consideration to also think about. Patient or the staff that is drawing the blood at pediatrician visits. So just being aware of that. But I agree with you that I have seen some remarkable outcomes in patients, especially treated after identification by newborn screening, that have been treated with gene therapy. It's quite a new world for SMA. I think to move on to the third drug, risdiplam. So this medication was initially tested in type 1 infants who were anywhere between 1 to 7 months of age at screening. And in this slide, you can see in the graphs that the natural history kind of information from the PNCR shows, as we would expect, a pretty significant decline in survival, down to less than 40% at 12 months of age. And then in the clinical trial, a firefish, 85% of infants were event-free, meaning 93% were alive at 12 months. So pretty remarkable deviation from the natural history curve. And in the initial dose finding study, there were good results as far as the ability to have upright head control, sitting either with or without support. Close to 2/3 of patients were able to do that. Thinking about the fact that these are type 1 children who are never expected to sit, let alone be sitting, relatively close to on time. About 41% were able to sit without support for 5 or more seconds. And then again, similar to the testing or the numbers in the Nusanierson trials, they looked at the percentage of patients that were able to achieve a CHOP INTEND score of greater than 40, which was about 59%. So that was the first study. In the second study, the confirmatory study, they looked at other endpoints. In the studies looking at types 2 and 3 SMA and risdiplam, it was a placebo-controlled trial, and they also met their primary endpoint of change from baseline in the MFM32 after 1 year of treatment, compared treatment versus placebo. And these changes were statistically significant in both the upper limb and the MFM for these patients. So just remarkable kind of deviations from what we typically know happens with SMA. I would say that we can discuss the potential side effects to risdiplam. And they differ a little based on which type we're talking about. But in types 2 and 3 SMA, I would say fever and diarrhea, as well as rash, are the most common side effects that are greater than 10% in double digits. And then for infantile onset or type 1 that are greater than 10%, it's upper respiratory tract infection and pneumonia, as well as constipation and vomiting. We have information about patients that were 12 to 24 months after after treatment, and these are children or people aged 2 to 25, and they were found to maintain the improvements that they gained between 12 and 24 months. They've had increased motor function in the measurements that are used. And then they also had kind of either improved or stabilized motor function. I think it's a little more challenging with risdiplam to have as much real world experience, because it's really only been approved since August. But Crystal, I'm interested what your experience has been with risdiplam.
I have several patients that are on risdiplam now. I have many patients who have been on one of the 2 other treatments previously. And so in particular, probably a significant number of patients of mine are on Nusanierson, and felt like they were doing so well on their Nusanierson treatment that they had no interest necessarily in transitioning to a different agent, with concern that they may have a difference in efficacy. And so the patients that I have been able to treat with risdiplam really have been some of my patients who either refused to receive treatment with Nusanierson, or patients who had some sort of structural or otherwise social barrier to pursuing treatment with Nusanierson. And so for this reason, many of my patients are older or more complex, and perhaps much weaker because they have that more severity of phenotype in their older age. So I'm looking forward to seeing what outcomes they may have over time. And some of them have experienced some of these adverse effects with GI distress, but only one of them has had to come off of therapy. Due to that, the rest of them have been able to proceed with treatment.
So I think in the next few slides, Crystal is going to cover some payer perspectives and cost considerations.
So pharmacoeconomic models incorporate many factors, including costs of medications, impacts on lifetime healthcare costs, quality of life for patient, and burden on caregivers and family. Lack of data creates uncertainty regarding the potential long-term safety and durability of clinical benefits, the safety and efficacy of concurrent or sequential use of multiple therapies. Generalizability of results becomes something of discussion from trials with stringent eligibility criteria, and some of our patients don't fit into those exact molds of inclusion-exclusion. And how do we best assess the clinically meaningful treatment response to inform continuation, to inform decisions about continuation or even transitioning or switching? Before we get a little bit more into this, I thought we'd start with a poll. Healthcare utilization and costs for patients with SMA. This is data from SMA patients obtained from a large managed care population using claims data from 2006 to 2016. And patients for this purpose were classified as infantile, childhood onset, or later onset based on their age at diagnosis. And they were matched one-to-one to non-SMA patients based on age, gender, geography, and health plan. And results demonstrated that the mean per member per month costs in SMA versus matched non-SMA patients was $25,517 versus $406 for the respective groups in the infantile patient population. In the childhood onset population, the mean per member per month cost was $6,357 for the SMA patient versus $188 for the non-SMA patient. And for the late onset group, $2,499 per member per month in the SMA patient group versus $742 per member per month in the non-SMA patient group. And so the conclusion was made that SMA patients, particularly with infantile onset, incurred significantly higher healthcare utilization and costs than the general population. So talking a little bit more about payer perspectives, what if a patient doesn't fit the eligibility criteria of clinical trials, but might still be expected to derive benefit from treatment? And I think that this is where we go back to our understanding of pathophysiology and neuromuscular disease and pathophysiology of SMA, recognizing that this is once again a degenerative disease. There's no such thing as stability here. And so intervention that leads to stabilization or a slowing of degeneration is going to be success. And so this is the rationale for the discussion about including patients in treatment who may have not necessarily been addressed in clinical trial if the mechanism of action is appropriate. And this is where mechanism of action of some of those medications that we've talked about are critical to understand. And so clinicians can document all aspects of a patient's response to treatment. So for example, I have patients who are a 0 on the Hammersmith. They may be a 0 or a 1 on the revised upper limb module. And so how am I tracking their progress and their treatment? Well, I'm tracking their progress in treatment, perhaps with PFTs, showing that they have stabilization or a slowing of degeneration in their neuromuscular restrictive lung mechanics. I'm talking to them about quality of life. So maybe they're a businessman that doesn't have to ask for help anymore to flip the light switch on in his office at work. And so these are things that we talk about that may be noted in the documentation supporting either authorization or continuation of treatment, and things that we try to address that may not necessarily have a score attached to them. Initiating and switching therapy, let's discuss some payer and clinical perspectives. And I'd like to actually take a question. Have you combined onasemnogene with the other treatments, and what is the reason for dual therapy? And I actually have, several patients who received onasemnogene abeparvovec and subsequently demonstrated improvements in their motor outcomes, but still were symptomatic because remember, we don't have a cure for this disease. So they were still symptomatic from their disease process, and there was the potential to perhaps optimize their outcome. And I had the ability to provide additional Nusanierson treatment. And I saw improvement in efficacy in those patients that I have treated, with improvement in motor function and respiratory and bulbar function. I'm hopeful that we will have some data in the future that will help to support that thought process. And there are some clinical trials ongoing that are going to hopefully address that question. So we don't have tons of data yet about switching between treatments or adding treatments, but we anticipate that more data will be coming in the future. It's important to keep in mind that time is motor neuron, and the earlier the treatment, the better. So talking a little bit more about payer perspectives on access. So the speed of approval actually is going to vary by payer, and delays in actually administering treatment from the time that we have received approval may come from several different variables. One variable is whether or not we're obtaining this through a specialty pharmacy, for example, and we may have to wait on a letter of agreement between the specialty pharmacy and the payer. And so that can lead to delays. Denials may happen and may need to be appealed. And we try and do this in as timely a fashion as possible, because remember that once again, time is motor neuron. And once a motor neuron is lost, I cannot get it back. This is about preservation. In the case of policy exclusions or denials that cannot be overturned, patients or caregivers may reach out to the manufacturer. More often than not, it's not necessarily that these medications can be just given, but that there are some policies in place to help facilitate access to support. So, for example, copay assistance programs and things like that. So let's go back to the question on Nusanierson. Which of the following patient populations treated with Nusanierson showed the greatest improvements in the Heine motor milestone scores? So it looks like we've provided some good information here, Erin. The correct answer is 2. Pre-symptomatic infants with type 1 SMA showed the greatest improvement in the Heine motor milestone score. And this really is demonstrative of the effect of early initiation of treatment and what supported the initiation of consideration of newborn screening. So here's another question that you saw earlier. Which healthcare category has the biggest impact on medical costs for patients with infantile SMA? So the correct answer is C. The correct answer is C, inpatient services. Now let's turn to the third and final learning objective, which is to recognize the individual patient and caregiver-related factors that guide clinical decision-making in spinal muscular atrophy management. Erin will start us off with a poll.
Yes, so which of the following SMA treatments is approved for use in both neonates and adolescents? So now that we have 3 different treatments that are FDA approved, there are considerations, I think, when I'm discussing with families trying to make a decision about treatment. And so some of the factors that are considered are the age of the patient. So as the chart shows, Nusanierson is approved in patients of all ages with SMA. Anasamagene Parvovex is approved up to age 2 years, or just before they turn 2 years. And risdiplam is approved for patients who are older than 2 months. So the age of the patient can definitely play a role in which therapies we're discussing, less so in patients who are identified by newborn screening. Risdiplam would not necessarily be available to them unless they're waiting. And then older patients are not eligible for gene therapy. Oftentimes parents have done quite a bit of reading and have an opinion or thoughts about which treatment they want their child to receive. So that's a discussion, and their opinions are definitely taken into consideration. Again, because of the way that some of these, the medications are administered, kind of different characteristics of the patient. So somebody who has significant scoliosis or kyphosis, it may be more challenging for them to receive Nusanierson. And then patients who are interested in receiving anasamagene Parvovex have to have anti-adenoviral antibodies checked, because if they happen to have antibody titers, then that treating them with gene therapy could potentially be risky. And then sometimes discussing the risk-benefit ratio for different families. And although guidance is that patients with 4 or fewer copies should be offered treatment immediately, some families have thoughts about if they aren't expected to show symptoms immediately, which treatment do they want their child to start with or to receive. And then, I think the other thing that is becoming more of a consideration now that risdiplam is available is, how do these treatments affect patients who are more advanced in their disease? And these patients are often older, and so are, making decisions about these treatments for themselves, and it's not necessarily the parents' thought. So I think my practice is to offer treatment to any and all patients, especially those that are identified by newborn screening. I'm curious if you have other considerations that you take into account, Crystal.
I think each of these that you've mentioned are things that become part of my conversation with the families and with the patient, and it becomes an open dialogue talking about pros and cons and the potential unknowns for the future.
Yes, so I think the other thing to remember as far as treating for patients with SMA, even after treatment, all patients are going to continue to require multidisciplinary care, because this is still a significant disease that is affecting many different of the body systems, particularly pulmonary and orthopedic, as well as some of the rehab needs. So I think to move on to talk about, now that treatment is available, how does my practice change? So, we are now having discussions, instead of talking about, how severely these patients are going to be affected and how many months they may survive. We're now talking about, okay, we need to think long-term if these patients are going to survive. And what do we need to think about? We need to think about their breathing during sleep, since they're not going to be on a tracheostomy with a ventilator. And, what do we need to think about as far as equipment? And if they are more functional, we want to make sure that they socially and emotionally are engaged with their peers. And so, introducing, power chairs at an earlier age so that they're, able to participate. And then I think, thinking about what we're doing as far as bone health goes. So optimizing vitamin D and thinking about referrals to orthopedics if needed earlier. And then I think, to think about the fact that this disease is so encompassing for the families, that this is something that it affects the entire family. It affects the parents obviously significantly. And, thinking about how patients are doing emotionally and socially. And sometimes as they get older, thinking about whether, counseling or social work can be helpful in just making sure that things are going well for the families, and keeping them engaged with their environments as well. So we're going to get to case study number 2. We have a pre-symptomatic newborn girl who tested positive on newborn screen. She had subsequent confirmatory testing that says she has 3 copies of SMN2. I think thinking about, talking about treatment with the family. So I think I would immediately check AAV9 antibodies to at least know if this is an option for treatment. And I tend to lean towards using gene therapy because it is only available until someone has turned 2, but it's not always the case. But Crystal, I'm interested in how you would think about this patient if she had 4 copies of SMN2.
Yeah, Yeah, so I think as we had talked about a little bit earlier in the program, if this is a child that has 4 copies of SMN2, this is a patient that has spinal muscular atrophy. And while I know that the greater the copy number, perhaps the relative better the phenotype, I don't have a one-to-one genotype-phenotype correlation. And I can't tell this family that this is a child who, won't have weakness until such and such age. So they need treatment. They need treatment immediately. And I would discuss with them the potential to pursue intervention with either Nusanierson or on onasemnogenic Parvovec. And part of that discussion would include obtaining antibody titers. And if those antibody titers are elevated, obviously, then that is a patient who doesn't qualify to receive onasemnogene at that moment. And perhaps I would initiate treatment then with Nusanierson. I think while we're on this case, what's interesting is that there has been a question that's come across that is asked, what's the life expectancy for a child with SMA? And I think that the great thing is that I don't have an answer to that question. And I am excited that we don't have an answer to that question, but an excellent question nonetheless, because just 4 short years ago, I would have had a pretty definitive answer to that question, which at least would have been for the phenotype 1 patients, 2 years or less. So let's move on to case study number 3. We have a symptomatic 8-month-old who is diagnosed with spinal muscular atrophy and has 2 copies of SMN2. So this is an older baby. And so Erin, how would you decide on or discuss treatment with this particular family?
So again, I would be checking, starting with antibody titers to see where we are, see if gene therapy is an option at all. I think, urgency is utmost in this case because they are already symptomatic. And regardless of which treatment is picked, I would probably have my pulmonary colleagues seeing this patient the same day or immediately to be, doing some preventative talking with the family and making sure they're set up at home. But I think, this patient is obviously eligible for all 3 medications, and it's sometimes I take into account, how much the family, how far they live from the center is coming, on a regular basis to receive Nusanierson going to be challenging. Do they think that giving a medication every single day at the same time after the child has eaten, is that going to be really challenging for them? And, those are different, considerations. And then, I've had a couple of patients who we gave gene therapy, but mom was pregnant. And so that takes, a lot of thought and working to make that work and make sure we're being safe. So it's an ongoing discussion.
Absolutely.
Yes. So case number 4, this is a little bit older of a child. So we have an 11-year-old with type 3 SMA and some complex spinal anatomy. So, I think I would obviously would be offering either risdiplam or Nusanierson. And if this patient had already, previously told me that they had not been on treatment because they didn't want to receive lumbar punctures, then risdiplam might be a good option. But I know, Crystal, you have some experience with complex spinal anatomy patients, and I'm curious to hear from you.
I do. Actually, some of my patients that have complex spinal anatomy, I can still access with a traditional lumbar puncture. And so I continue to use a very traditional approach, no sedation, and just a traditional lumbar puncture with intrathecal infusion. There are some patients who may have rods that obstruct my ability to be able to gain access. And so I involve my interventional radiology colleagues, and we use fluoroscopy to gain access, and that has proven to be very fruitful. My interventional radiologist has also been able to gain access at the cervical level to provide intrathecal infusion of Nusanierson, and that has been well tolerated as well. And then there are times where we would consider a laminectomy If this is a patient with full fusion who doesn't either tolerate cervical injections or doesn't appear to be the right candidate for that. And we can create a bone window to pursue maybe a more traditional lumbar puncture with the assistance of fluoroscopy that way.
So for our last case, we have an adult, a 25-year-old man who has type 4 SMA. He has 4 copies of SMN2 and is walking independently, but he is fatiguing easily. So I don't have adults in my practice, but I would assume that he's going to be helping make this decision too. So Crystal, how would you decide with him on treatment?
Yeah, I have my 68-year-old patient. His history goes something like this, and so he was in law school and noticing more tripping and falling, more fatigue, and so at the time, it's important to consider, the lifespan of this patient, which is expected to be very good, and his goals and aspirations. And so, if we were to pretend that this guy was in law school, he's got a lot of years of hard work ahead of him, and perhaps he wants to get married and have a family. And these are goals that we talk about, and how do we pursue those goals? And in order to be as independent as possible, and perhaps for this patient to discuss quality of life, I would recommend treatment, because once again, I highlight that there is no such thing as stability when it comes to SMA. Even if you feel stable, which my patients will tell me, your motor neurons are not, and they're continually deteriorating. And so in patients I've had like this, I would discuss with them the data on Nusanierson. And if for whatever reason they were not inclined to pursue that, or did not tolerate that, I could also discuss with them the opportunity to take risdiplam.
Okay, so let's go back to the question. So we're counting neonates as up to age 28 days. So actually the correct answer is A. Technically, risdiplam is not approved in neonates. Risdiplam is approved for ages 2 months and older. So the answer would be just Nusanierson. So it's been very enlightening questions.
Thanks, Erin. That's a great discussion. I'd like to summarize with a few SMART goals that are actions that you can use in your practice to improve care. Ensure genetic testing for early diagnosis. We've talked about these clinical trials, and in particular, the clinical trials involving pre-symptomatic patients, and they definitively show optimized outcomes or improved outcomes compared to the patients who were treated later and much more symptomatically. Ensure prompt access to treatments, because the data does suggest that early treatment leads to optimal outcomes. We can think about the SPRINT and the NURTURE studies. Implement strategies for multidisciplinary care coordination for patients with SMA, guided by a neuromuscular specialist. And this is really critical. We emphasize to our patients that I do not have a cure. Your patient, your child, your family member, your loved one still has a diagnosis of spinal muscular atrophy. And even if you've received gene transfer therapy, if I test your DNA, it's still going to show that you have spinal muscular atrophy. And so you need to continue to receive standard of care, and that is guided by a neuromuscular specialist and supported by a comprehensive team, the members that we talked about earlier. So that is absolutely critical to maintaining care, especially when we still have so much more to learn about outcomes. We need to coordinate with payers on availability of data for medical necessity determinations, and have open discussions with payers and providers around treatment regimens to optimize the plan spend. We have a lot of questions, and so I'd like to start with a couple that have popped up. What is the most common cause of death in the patients who reach adult age? So we can speak to that from a historical perspective. I think in my experience, it has been respiratory failure or respiratory failure as a consequence of acute infection. Erin, anything else to add from that perspective?
No, I would say it's respiratory is the main cause, plus or minus infection.
Are there reports of parents or family members who tested negative for AAV9 antibodies before treatment, but positive after treatment? And if not, why the precaution to glove and wash hands? And this is a really great question, and it's something that I try to get ahead of when I'm using onasemnogene abeparvovec. And I talk with my families about it's more out of precaution because we don't know what the potential for gene transfer therapy might be in the future. And so we'd like to reduce exposure in the event, say, for example, that family would be pursuing expanding their family and having more children in the future. And we'd like to prevent antibody positivity. Or if perhaps that mom or dad might need some sort of therapy in the future that might involve the same vector delivery for gene transfer. So it's really out of an abundance of caution, not necessarily because of toxicity. Erin, anything to add on that? Is there anything else that you talk about with your patients regarding gloving?
No, that I would say that's a good summary.
I think we've touched on this a little bit, but still important. In your clinical practice, what is the treatment approach for your pre-symptomatic patients?
So I think for me, I tend to, again, this is maybe a bias, but I tend to err on at least introducing the idea or the option of using gene transfer therapy if they are not antibody positive, mainly because I've had very good results in my pre-symptomatic patients. But we have a conversation about, if that's not something that they're interested in, or, for some reason being on daily steroids is, potentially going to be an issue or a problem. So I think, pre-symptomatic patients, I tend to offer all three. But if families ask me my opinion, I usually say, well, we're limited in the amount of time we're going to have availability of or eligibility for an onasemnogene abeparvovec, and that's tends to be that's one of the things that I have as a consideration. How about you?
Absolutely. And I think actually one thing that that's worth noting is the word pre-symptomatic. There's a lot of discussion I know amongst our colleagues whether or not that actually is a term we should use, because I think the symptoms are in the eye of the beholder. And so perhaps we're seeing, mildly less kicking in a neonate, or, somewhat poorer head control than might be noted in a typical child. But it's hard when you have the answer in front of you and then you're examining the child rather than examining the child and then sending off for the genetic testing. So it's a different approach with the babies identified either prenatally or on newborn screening. If you have side effects because of the steroids, do you consider switching the patient to Nusanierson? So, we have to keep in mind that the steroids are transient. They are really only for 2 months, perhaps a little bit longer if you have a transaminitis that persists, but not something that is continued. It is really meant to address and mitigate the transaminitis that happens with onasemnogene abeparvovec. Erin, question for you. As a clinician on the payer side, what should we look for in a request for covering a patient who may not fall into the inclusion criteria, or to justify approving an exception to that criteria? What are your thoughts?
I think if the person who's submitting is able to be documenting, how the patient has been deteriorating, what their symptoms are, what's causing them difficulty, and where the person submitting is indicating they think that the patient could be helped. I think we're having more registries, so submission of some information about, that there are registries being kept to look at these symptomatic patients, even though they're not, they aren't fitting within the strict criteria. So I think those are kind of some of the things. And then I think just being able to document, okay, this is where someone is on their motor milestones, and also I think looking at their pulmonary function, because that's also something that can be measured over time.
Great considerations. As a reminder, to receive CME CE credit for today's program, follow the steps described on this slide. Thank you again, Erin. This has really been a great discussion, and thank you, our audience, for all of the great questions that you sent in. We hope that you'll be able to use these discussions in your practice. Thank you again for participating and for providing the best care for patients.